Hi, I'm Seth Truger, Digital Media Editor of JAMA Network Open. Welcome to JAMA Network Open Live.
And I'm Mike Berkowitz. I'm Electronic Editor of JAMA and the JAMA Network.
If you're watching live, be sure to follow along and enter your comments or questions on our Facebook stream under the comments, or respond to us on Twitter at JAMA Network Open.
And we're going to review important articles from the latest JAMA Network Open release. But first, Seth, are you wondering why we're wearing these ridiculous hats?
Well, it's winter in Chicago. It's cold outside.
It's winter in Chicago. Despite climate change and global warming, it's still cold outside, and we're in the holiday spirit.
Right. Plus, who doesn't love a good pom-pom?
Exactly. Pom-poms are back in fashion. This kind of reminds me of Bob and Doug McKenzie. That may be before your time, but they were two Second City comedians who had a talk show, an improv talk show that looked kind of like us.
Yeah.
They were Canadian comedians who improvised, and they would say things like good day and take off, and really something to look for on your YouTube channels.
Yep. I know a little bit about what you're talking about.
Right. Okay, so what do we got, eh?
All right, so the first paper we have is the association between early intravenous fluid provided by paramedics and subsequent in-hospital mortality among patients with sepsis by Daniel Lane and colleagues.
Sepsis is crucial, Seth, because we know that we don't recognize it enough and it can be lethal. So early IV fluids, tell me what question this article is looking to answer.
Right. So in the last 15 or 20 years, we've had a lot of good questions about how much patients should get in terms of fluids and early administration of aggressive fluids, especially since the early goal-directed therapy trial from 2011. One of the questions that this paper is trying to ask is, do patients who get early IV fluids when they're in the ambulance by the paramedics, do they do better than patients who didn't get IV fluids early on?
Right. So from my perspective, these patients are potentially unstable. You're going to establish IV access, and you're going to run a line and run some fluids in no matter what. Is this giving a new view of that practice? Are they saying we shouldn't be running fluids preventively in these patients?
They're not saying we shouldn't. So first of all, this is an observational trial. They're not randomizing patients or looking prospectively. But they did look at what happened to patients and what the patients looked like and how they did. And what they found is that the patients as a whole didn't do better with fluids pre-hospital, but the patients who are hypotensive, the sicker patients, did do better when they'd gotten fluids.
So patients who have lower blood pressures do better when they get how much fluids, did they say? Yeah,
so again, this wasn't a trial, this is observational. So the patients who got fluid boluses got an average, I think it was 500 cc's of saline. Some of the, overall, the patients who got fluid got an average of about 400 cc's of saline.
So about half a liter, if you're hypertensive, seems to be associated with reduced mortality pre-hospital. So when they hit the ED, this is all pre-ED intervention. And what about patients who weren't hypotensive?
Yeah. So patients who were not hypotensive didn't seem to do any better than patients who didn't get fluids. Obviously, there's going to be a lot of different variation in this, things like transport times and expertise of the staff you have. One of the things that, as a study in the U.S., is these patients weren't being seen by pre-hospital docs like they are in Europe and sometimes in Australia.
Got it. So one of the questions that I had is that there is a non-statistically significant odds ratio for mortality among patients who weren't hypotensive. Right. And I think that's, for this study, is defined as 125 millimeters of mercury, systolic blood pressure. But the odds ratio was 1.4. So the point estimate is slightly above 1.0, and there's a confidence interval that includes that goes to 2.44. So there's maybe a non-statistically significant signal of harm here. And my one question is this pointing us in the direction of holding fluids or being judicious about fluids in patients who are normotensive?
Yeah. So I think, again, as an observational trial, this study can't really answer that question. And you can show if you look at figure 2, you can see the curve where basically at each individual blood pressure, what the odds ratios were of mortality, with the gray bar being kind of the error bars around that, or the 95% confidence interval. And as you said, as you go higher with higher blood pressures, patients do worse and worse with the fluids. That's not terribly surprising, especially since patients who are less sick are less likely to benefit from therapy at all. And also what we see sometimes is patients who are less sick or have higher blood pressures might have something else going on that looks like sepsis that isn't. Like they might just be in heart failure, and that's why they're sick or having trouble breathing or something like that.
Right, got it. So the sepsis diagnosis is actually one that's not necessarily there in place pre-hospital. It's the one that's made in the ED. Right. That's interesting. So I'm not an EMT, but I would think that I would want to kind of load a patient up with fluids if I thought they were septic, just to make sure they don't crump during transport. or decompensate as the proper term. Tell me how it's happening in the ED. Just tell me your clinical experience with these patients when they come through the doors.
Sure. So I work here in a big city in downtown Chicago. We have pretty short transport times, so it's probably less of an important question. The EMTs we work with are fantastic, and I think this is something that a lot of people I think are going to take what their priors were and reinforce them, and that's sick patients who are hypotensive are probably more likely to benefit from aggressive therapy, and probably the ones that the EMTs are taking more seriously. Patients who have good blood pressures probably less likely to benefit, so you probably don't need to get as involved. But I mean, I did residency during the heyday of early goal-directed therapy when we were really aggressive with fluids and early identification. And I think more than anything else, my takeaway on sepsis care is you got to find patients who are sick, and the sick patients who you identify, them you have to aggressively resuscitate. And that's reinforced by this, or I'm certainly taking it this reinforces my priors.
Got it. And so that's your second reference to early goal-directed therapy. Is that still evidence-based treatment, and can you define for viewers what that is?
So you just kind of answered your own question there, because I think for me, my first question on early goal-directed therapy, or when people ask me about my view on early goal-directed therapy, is what exactly do you mean by early goal-directed therapy? The original trial from 2001 by Rivers et al. Basically randomized people to whether or not they were getting very aggressive sepsis care based on continuous central venous oxygen saturation, which is not something that happens in the same way that it did in 2001. However, they also show that we basically started giving patients a lot more fluid than we used to, being much more aggressive with critical care early on. What I hear is back in the day, before I was in med school, patients who were septic would get a gram of ceftriaxone, a liter of fluid, and then put in the corner to wait for a bed upstairs. It's very different than what happens now. And the three kind of newer trials, was it Promise, Process, and another one with an A who I'm forgetting right now, basically showed that if you give people, you don't need a protocol to provide better care, but my takeaway was that the patients who are in both groups, the protocol or non-protocolized care, were getting a lot more fluid and a lot more aggressive care than we're used to back before the 2001 paper.
Got it. And one of the things that's been exciting from our end is that JAMA and the JAMA Network has been central to publishing the evidence in the evolution of the care of sepsis. We published the Sepsis 3 guidelines in 2016, and the validation of that definition in SOFA and the Q-SOFA score for predicting which patients were going to do poorly or require ICU transfer. And we continue across the network to publish articles about sepsis and that new definition. And for any of you who are interested, go to jamasepsis.com. That's our microsite that curates all of the stuff that we've published. We also have a topic collection. You can just search for JAMA and sepsis and it will come up.
Yep. And of course, while you're speaking, I remember the third trial was ARISE.
ARISE.
Yeah,
Okay.
That's the third of those three that came out around, I think, 2013, 2014.
Okay, so the bottom line of this study, just to wrap it all up for viewers,
is basically patients who are hypotensive probably do better when you're giving them empiric fluids for sepsis early on.
And that's pre-hospital, so we can maybe extrapolate to within the hospital. What they found makes sense, but probably might be a candidate for a randomized trial based on target or threshold blood pressures, because this is an observational study.
And I think that's one of the things that we're seeing in sepsis, as with everything else, that is going to be future studies on different subgroups to find out which patients and which types of patients do better. Because as we're learning, sepsis isn't one homogeneous group of patients. A lot of people have sepsis, and there's probably at least 6 or 7 different phenotypes of sepsis.
Fabulous. What do you have next?
Next, we have the association of early physical therapy with long-term opioid use among opioid-naive patients with musculoskeletal pain by Eric Sun and colleagues.
So PT for patients with musculoskeletal pain, for those patients who have never taken opioids before.
Right, and this is early physical therapy, which means not that it was pre-hospital like with the sepsis paper, but that they got it basically when they saw a doctor, whether they went to a physician's office or they went to the ER with something like neck pain, back pain, shoulder pain, and I think knee pain is the other one.
Okay, and just to be clear, a lot of studies distinguish between acute musculoskeletal pain and chronic pain. This is acute pain. This is kind of the initial presentation.
Yeah, they're calling it new diagnosis of musculoskeletal pain.
Got it, because that's not really a diagnosis. That's a kind of a...
Yeah, it's a chief complaint is diagnosis, which you know is our lived experience with a lot of these things. Most of the patients that I see with these kind of complaints, I diagnose them with something like back pain with left-sided back pain with left-sided sciatica. I don't go much beyond that, because
Right.
that's what we're seeing clinically, and
Absolutely.
that's what we can tell.
Right, that's the diagnosis. And so what did they do and what did they
Yeah.
find?
So they looked at a big insured database of privately insured patients from, I think it was the IBM Market Scan database. They had 89,000 patients from 2007 through 2015.
Okay.
It's observational again, so you know, a lot of this might be selection bias, but what they found is that patients who were referred to PT and started physical therapy early on actually did better when it came to managing their pain, and importantly, were prescribed fewer opioids down the road. This didn't hold true for neck pain, interestingly, but it did for the rest.
I got it. So when I hear that kind of thing, I imagine, without looking at that particular finding that closely, that that's just a chance finding. I can call this kind of a happy paper, in the sense that I'll declare a prejudice. Some of my best friends are physical therapists. I love physical therapists and I love physical therapy. It would just make sense that patients who have access to another human who's helping them focus on getting through or past their musculoskeletal pain will do better and will need less pharmacologic intervention down the line. Did they say anything about non-steroidals, over-the-counter medication? Like, I would put these people, in addition to physical therapy, on ibuprofen PRN as long as they're not taking it too chronically.
I'm sure they did, but I'm blanking in that specific detail right now, which I'm sure you're aware of.
Okay, yeah. Well, so I don't know the answer to that, but the other thing is, again, this is a private insurance, a privately insured patient population, so they have access to physical therapy. Presumably, it's a covered service. And we know that access to services, particularly, I think, we've also published in JAMA Network Open, non-pharmacologic interventions for chronic pain lead to improved outcomes. Physical therapy is one of them. It may be one of my favorites. Others include, I think, chiropractic for acute musculoskeletal pain of particular sorts. Tai Chi, meditation, things of that sort. JAMA Network Open has published on that, and so this is kind of a particular form of intervention in a very large population, and it kind of confirms what we would like to hear, which is that access to a physical therapist will prevent the adverse consequences of that being a patient being on opioids long term. Love that.
Right. Yeah, absolutely. I mean, we don't know necessarily, we don't have great prospective data on whether or not PT is helping these patients, but we know that patients who are getting PT do better. And we know opioids are very bad for you. So if it's something that we can do to decrease opioids use, I think it's helpful. I also find in my experience that a lot of patients in these situations, we don't have a lot to offer them, and just saying, I'm not giving you opioids because those are bad for you, go home and be in pain. Obviously, I would be a little nicer than that, is hard. So having one more potential tool in my tool belt to help them with, especially if it's people who we can plug in with PT. We have a physical therapist in our emergency department during basically banker's hours, which is great. And my theory is that he's able to, assess patients and help figure out who may benefit from PT early on, which is great. And plus, it helps me, show that I'm caring about the patient, communicate with them about what we're trying to do to help, and not just say, nope, not giving you a script for Norcos.
Right, exactly. So that's great for the ED setting, and I was going to kind of sing that same tune again that I've said now on a couple of these JNO live episodes, that having another human paying attention to a patient and engaging in a relationship with that patient around chronic symptoms that the doc can't quite pin down is probably itself therapeutic, which is not to dismiss the specific benefits that come from physical therapy, but I think that human relationship makes a difference, and docs can't give that up to patients frequently, at least in the constrictions that they have in offices and in clinics. So having a physical therapist on board, 2 thumbs up.
Yep, absolutely.
Great. And we have one more paper, I think, lined up.
Yep, one last paper today. The Association of Timing of Sexual Partnerships and Perceptions of Partners' Concurrency with Reporting of Sexually Transmitted Infection Diagnoses by Catherine Mercer and colleagues.
So that sounds like a lot of words to kind of throw people off from the fact that we're talking about sex and STIs, or sexually transmitted infections. Wow, so we don't see a lot of that in the pages, at least of the JAMA Network, as much anymore as we used to. Tell me which STIs we're talking about and what's going on in here.
What are they looking at here?
Well, just tell me what they did to start with.
So basically what they're doing is they're trying to see if the reported gaps patients have between being monogamous correlate with how much they think their partner may be exposed to STIs through another partner, or how much their gap between serial partners correlates with them reporting having an STI.
So it's the time since the last sexual encounter or sexual partnership.
Right.
And I believe it's also the perceptions of one partner that their other partner may be sleeping around. Is that right?
Basically, yes.
Oh.
How many partners do your partners have?
So, okay. Right. And
Right.
back in the day, at least in the HIV era, which is when I was training, I'm kind of dating myself here, there was the old saw that kind of put a little bit of a, kind of took some of the air out of our collective balloons, which is that when you sleep with somebody, you're sleeping with every person that that person ever slept with. And I think that's what's going on in this paper in terms of sexual networks, right?
Yep, exactly. So if you look at figure 1, they look at the gap between a current person's current partner and their next partner or their last partner. And it's kind of interesting when I was first looking at this paper, it was kind of took a minute to figure out what they meant by the negative numbers here.
I was going to ask you about that because the figures have negative numbers in terms of the time since the last partner.
Right, yeah. So basically,
that seems like time travel to me.
Yeah, exactly.
Okay.
So basically you're saying, if the person A breaks up with their partner B and then goes to date partner C and the gap is negative, that means that partner C probably started while they were dating partner B in the first place.
Got it. So partner C's consorting, right, while they're with partner A.
Right, exactly.
Interesting.
Yeah.
Okay.
Not surprising, patients who had more overlap of their relationships are more likely to have report that they had sexually transmitted infections.
Okay.
And not surprisingly, people who thought that their partners were cheating on them also were more likely to report that they had sexually transmitted infections.
Okay, and you said report that they had sexually transmitted infections. I think that's an important methodologic component of this paper, which is that these are self-report. Right? So there's two aspects here that I found interesting. They did computer-structured interviews, if I understand correctly. So it wasn't a human asking the participant whether they had sexually transmitted infections. They were able to report it presumably with a perception of confidence. They were kind of just reporting it to a computer and the data were collected.
Right, and like we talked about in a previous episode, with sensitive information like this, patients are oftentimes reluctant to talk to their doctors about it because they could be embarrassed or feel guilty or, I don't know, this is just yucky personal stuff to talk about. So it's probably more likely to get a truthful answer from a computer where it's a little dispassionate.
That's what I would think. Another component that I think you didn't mention is that this is a UK or a British population. This isn't United States or other countries. This is specifically a national survey sample in England. And there was a 50% response rate. I wasn't quite sure what to do with that. It's a national survey sample.
Yeah.
Like I suspect that they have 100% capture for other things, 50% capture for the reveal of sexual activity in partnerships, right?
Yeah.
So we don't really know how that non-responsive kind of population compared to the people who actually answered these questions here.
But as you can see, these, there were, it was the response rate is 57.7% on these sensitive questions, and they were talking about things like cheating on their partners and reporting STIs. So if anything, I think, it's unlikely that there were patients, who are. It doesn't seem likely to me that patients weren't responding because they were embarrassed to give answers that they were cheating or had infections, basically.
Got it. And given the evolution of our culture towards more tolerance, acceptance, and of LGBTQ populations, and the need for physicians to be more in tune with them, is this a heteronormative study, or is this a? Did they pull out same-sex versus opposite-sex kinds of relationships here?
You know what? I don't know. To look up, but we do have a question from Kedaman, Min Lakong from Australia.
Oh, hey, Min.
How are you doing, Min? So he's asking, so is this a paper about serial monogamy? So it's about ostensible serial monogamy, but what we find is that a big fraction of patients who are ostensibly monogamous actually have concurrent relationships because they have negative gaps or more than one partner at a time.
Right. I do think that one of the findings in this paper is that people who have more than one partner, the majority of them, by about 60 or to 70%, were serially monogamous. So that's where the multiplicity comes in, and this is the number of partners within the past 5 years, at least the way I read it.
And it's not just that cheating leads to STIs, but they also found for patients who were actually monogamous, there was an increased rate of reported sexually transmitted infections among patients who had shorter gaps between their serially monogamous relationships, even if they weren't actually cheating.
Got it. And then the other question I had, which I don't think is answerable with the data they give us, is which STIs are we talking about? I presume we're talking about chlamydia, and maybe GC, gonorrhea. But there's HIV is an STI, hepatitis B is an STI. So it's really what the patient's perception is.
Right.
And I imagine among women, and this is purely speculative, that a bacterial vaginosis, might be considered an STI if the doctor kind of associated the symptoms the women were having with sexual activity, for example.
Yeah. And usually we don't ascribe BV to being sexually transmitted. Trichomonas, yes, but not BV.
Right. Okay, so I just I wanted a little bit more clinical detail, but understanding that this is a national survey study, it's good to know. And then there is an accompanying invited commentary talking about the epidemiology of STIs. It's really a welcome addition to the literature because, as I've said, this kind of topic seems to have fallen out of favor as a subject of clinical research and of epidemiologic research, at least in the papers of clinical journals, CDCs and other kinds of data gathering organizations are focused on this.
Right, but these are relevant topics because there's a lot of other overlapping areas like the demographic changes of people living longer, healthier lives where we're seeing the geriatric population have more STIs come back. We're seeing a bit of a resurgence of syphilis.
Right.
We're seeing one of the downsides of the success of PrEP for HIV is that some sexually transmitted infections are more likely to come back, like gonorrhea and chlamydia in populations who are practicing PrEP. It's tough, so lots of questions to answer on this stuff, and the more we can talk about it, the less stigma there is so we can get the good science on it.
No better words have been spoken in a JNO Live episode than that. So I think that's a wrap, right?
Yep, that sounds good. So be sure to follow us on Facebook, Twitter, and LinkedIn at JAMA Network Open.
And check out our new releases every Friday at 10 a.m. Central Time in the United States. And you can do the calculation for the time of release in your own country. And follow us on Facebook, Twitter, LinkedIn, anywhere you get your information, because JNO is only growing. And we want to see you again here. Yep. And when are we going to be back?
We're going to be back in early January, as you can tell by our winter pom-pom hats. It is the middle of December, so we are.
I need my sleigh bells. Jing, jing, jing,
right.
jing, jing.
So we are going to be taking off for the next 2 weeks. So come join us again at the beginning of January.
Okay, fabulous, and we'll put some links maybe to jamasepsis.com and the Bob and Doug Show in the comment section on Facebook at least. So take care, guys. Thanks for joining us. Thanks for your comments, Min, and anybody else. Please follow us, and we'll see you soon.
Thanks, and stay warm.
Take care, guys.